It concerns an 80-year-old man who presented to an emergency room with abdominal pain in the right upper quadrant. Murphy's sign was positive. That means that when he breathed in and his liver came down, the examiner's hand was below the right costal margin and the patient perceived pain. If we look at this CT, we can see the liver, we can see air in the stomach and small intestine, one kidney on one side, the bit of the kidney on the other side, and this is the gallbladder, and the wall of the gallbladder is filled with air. That's diagnostic for what we call emphysematous cholecystitis. These other possibilities are nonsense. And emphysematous cholecystitis implies that the bacterial infection involves the wall of the gallbladder, and one of the bacteria is producing gas. And Escherichia coli that produce gas are common, and they're probably responsible for this picture. I believe this patient was operated upon and actually did okay. The first topic at the New England Journal involves a surface molecule on T cells called CD3. CD stands for cluster of differentiation, and there are hundreds of proteins that have CD designations, and this is CD3. And CD3 is involved in signaling between antigen-presenting cells, such as dendritic cells, and T cells, giving the T cells messages, and the messages here involve activation and proliferation of T cells. And the T cells that are involved here also express CD28, which is another molecule on T cells. And there are antibodies already available against CD3 to try to inhibit the activity of T cells, and muromonab is an example of an antibody that's used actually after transplantation in patients that have steroid-resistant rejection. But that's not the topic for today. Now, 40 years ago in the New England Journal of Medicine, that would be 1979, there was an interesting paper published, the first to suggest that type 1 diabetes is an autoimmune disease. And in that paper, patients were described that made antibodies against insulin. Our current perception is that type 1 diabetes is indeed an autoimmune disease, and that T cells are involved here, and that T cell immunity is responsible for destroying beta cells. So if we can break the relationship between antigen-presenting cells and T cells, perhaps we can inhibit the negative effect of T cell immunity on beta cells. Now, the propensity to develop type 1 diabetes is fairly strongly influenced by HLA class types, and there are various risk factors that are shown here that will also play a role in the paper that I'm going to show. Now, in this particular study, patients were recruited that were first-degree relatives of persons with type 1 diabetes. Now, first-degree relatives of patients with type 1 diabetes have a substantially greater risk of developing type 1 diabetes than the general population. And we can pick these patients by making measurements of whether or not they produce autoantibodies that are associated with the development of type 1 diabetes. So these first-degree relatives were recruited, and 88% of them already had antibodies against glutamic acid decarboxylase 65, which is probably the most common target that we see in patients that have autoimmune-mediated type 1 diabetes. But there are also antibodies against microinsulin and antibodies against islet cells, etc. The patients were recruited that had these antibodies, and then they were randomized to teplizumab or placebo, and subsequently observed. Now, the teplizumab, as I believe, was given as a single dose, which then had to last the patients for an extended period of time. And what we see here, the teplizumab group is in blue, and the placebo group is in red, and indeed the patients that got teplizumab, their proportion of being free of type 1 diabetes was substantially better over time than the placebo group, so that the development of type 1 diabetes in the teplizumab group was 48 months compared to 22 months in the group that got placebo, and the greatest effect was seen early within the first 12 months. So the implication is that teplizumab in these high-risk individuals might at least inhibit the development of type 1 diabetes. The question remains unanswered whether or not, if they got continual teplizumab treatment, if they would be protected for a longer period of time. One major issue in this report is adverse events, and teplizumab might cause lymphopenia. I guess we would expect that since it's directed against T lymphocytes, and rashes also occur. So if we look at this effect, the teplizumab group, and teplizumab was only given at a single time point, they had lymphopenia. But then at the end of a month and a half, their lymphocyte count was back up to normal, and the distribution of their lymphocytes was also different than in the placebo group. And you can look at the details in the figure. Now, there are subgroup analyses in this forest plot, and it looks like pretty much everybody profited, with perhaps the exception of people that expressed HLA-DR3 or HLA-DR4, where the beneficial effect of teplizumab was not as pronounced. We might also imagine that individuals that already have low levels of C-peptide are more advanced than individuals that have higher levels of C-peptide, so that difference is also shown here. So it appears that in a 2-week course of teplizumab delayed the diagnosis of clinical diabetes, type 1 diabetes, in these high-risk participants. So this is the first of these studies that, in my view, that has shown a positive effect. Similar trials have been done on patients that had a high risk of type 1 diabetes with cyclosporin or even and other immunosuppressive approaches, but this antibody approach appears much better. Now, the next topic in the New England Journal is a rare disease, neuromyelitis optica. That's an autoimmune disease, and these individuals develop cerebrospinal cord symptoms and blindness. 70% of these people have an antibody against aquaporin 4. And exactly how this works, I'm not really certain, but the reaction that ensues involves complement. And the treatment for neuromyelitis optica is unsatisfactory, as you might imagine. So in this particular study, patients with neuromyelitis optica that had antibodies against aquaporin 4 were treated with eculizumab. And you'll recall that eculizumab is a monoclonal antibody against complement factor 5. That's shown here. And this antibody is invariably given to patients that have paroxysmal nocturnal hemoglobinuria, because that's a complement-mediated problem. And this antibody is also given to people that have atypical hemolytic uremic syndrome, where it seems to have a salubrious effect. But it's also given to patients with therapy refractory myasthenia gravis. So this disease, neuromyelitis optica, has some elements that are somewhat reminiscent of myasthenia gravis, which is also an autoimmune disease. So these patients were aquaporin 4 antibodies positive. And they were randomized to eculizumab against placebo. And the primary outcome here, the endpoint, is avoidance of relapse. So the patients were evaluated in terms of relapse by their personal neurologist, and also by an adjudicating committee that looked at these data then after the study was done. And if we look at these patients, 96 in the eculizumab group, 47 in the placebo group, so they're randomized in a relationship of 2 to 1. neuromyelitis, transverse myelitis. These are awful neurological features. Immunosuppression had been given to these patients for the most part, glucocorticoids, azathioprine, mycophenolate, mofetil, and other treatments that are given for this unfortunate condition. And these patients can be scored with modified Rankin scales that we're familiar with from examining stroke patients, etc. And what we see here is, I think, quite remarkable. In the eculizumab group, only 3% of the patients had relapse. And in the placebo group, over half the patients had relapse. And whether or not this is evaluated in terms of concomitant immunosuppressive therapy or no concomitant immunosuppressive therapy, the impressive results were the same. And if we look at the evaluation as performed by the patient's neurologist or the adjudicating committee, the results remain impressive. Now, you might imagine that blocking complement might be associated with adverse events, and that was the case. Respiratory infections were more common in the eculizumab group, and the adverse events were also deemed more common by the investigators than the adjudicating committee. But however we measure it, it looks like the adverse events were tolerable in these patients compared to the awful sequelae from neuromyelitis optica. So there are some weaknesses to this study. Only patients that had aquaporin 4 antibodies were included here because their involvement with complement is so well established. Secondly, we don't know about long-term effects in terms of disability and quality of life because the endpoint was relatively acute in terms of relapse, yes or no. And the trial was also terminated somewhat earlier than the investigators might have liked. But on the whole, this is a fairly impressive result in patients that otherwise have a devastating course and poor prognosis. The next paper involves malignant melanoma, and this is a difficult diagnosis. We look in terms of patients that have skin lesions, and if the skin lesions are asymmetrical, if their coloration is heterogeneous, if the things grow larger than 5 millimeters, and if they evolve over a short period of time and are also flat, macular, as these lesions are. This one's not so macular, but these two are. That's suggestive that probably generous skin biopsy should be performed. So that's the topic. Oh, good God, what's this? Do I talk on the left? Okay, so that's the topic. And I was interested to see in a recent Science report that these skin lesions can also be evaluated by machine learning artificial intelligence algorithms. And we've already looked at articles where X-rays, CTs, and magnetic resonance imaging studies can also be evaluated by artificial intelligence. These skin lesions, we can teach the computer heterogeneity and irregular borders and size of these lesions. That can all be programmed into computers, and maybe computers are better at evaluating these things than dermatologists are. But there are vulnerabilities to machine learning, which is very popular today. And this little Science report discusses these vulnerabilities, and I don't understand this very well, but adversarial attacks can be conducted. And adversarial attacks against programs that judge items by artificial intelligence involves techniques to circumvent spam filters, for instance, but this can also be applied for medical machine learning. So adversarial noise can be produced Here's the original image of this malignant melanoma. That's actually a benign lesion as judged by the computer, and with adversarial noise, the computer then judges the same lesion as being malignant. Or if we turn these lesions by 90 degrees, we can also produce a malignancy from a previously benign score. So machine learning may be less than it's cracked up to be, but that's not our topic. But this is a problem, and we should be aware of the fact that although machine learning is all the rage today, there are problems, and machine learning programs can be hacked as well as other programs can. But at any rate, the topic here today is patients with malignant melanomas that are metastatic and increasing in size. And we know that these tumors commonly involve mutations in a protein called BRAF. And BRAF is a serine threonine kinase that is involved in this signaling from receptor to this small GTPase called RAS. Then we have the serine protein threonine kinase that signals MEK, then ERK signaling, this is MAP kinase pathway, and then we have transcription of target genes and proliferation and metastases and a bunch of things that we don't like. Now we have inhibitors against RAF, that's this serine threonine kinase that has a common mutation in patients with malignant melanoma, and we also have inhibitors against MEK. And these are novel treatments for patients that have progressive malignant melanoma. And one of the drugs is called darafenib, and this is a BRAF kinase inhibitor, and here's the structure here, and it's given to patients that have this BRAF mutation and at position 600 involving a V for E substitution. And what is discussed in this paper in the New England Journal is the use of darafenib against BRAF and trametinib against MEK in terms of 5-year survival in patients with unresectable metastatic melanoma that otherwise have a miserable prognosis. So this is not a randomized controlled trial. These patients all got the treatment, but we can break them down in terms of other markers that we have that indicate disease severity. So what we see here is, unfortunately, in the first 12 months or so, half the patients die of malignant melanoma. But with this treatment, the other half of the patients, this curve markedly flattens out. And in terms of their LDH levels, if their LDH levels are low, they flatten out pretty well. And if their LDH levels are higher, the patients do somewhat less well. And there's also a breakdown on whether or not there are less than 3 disease sites or more than 3 disease sites. And then the patients subsequently were also given other treatments such as program DEath1 inhibitors and CTLA4 inhibitors, etc. And they were also included in this analysis. But basically what we see here is that if the patients with malignant melanoma have a pretty much respectable LDH level, then their 5-year prognosis is not so bad, so that half the patients at the end of 6 years are still around. That gives some hope for the chemotherapy of malignant melanoma, which used to be a total death sentence and nobody made it out to a year. But with this treatment, numerous patients have an overall survival that's pretty much respectable. So the survival curves seem to plateau between years 3 to 5, and immune checkpoint inhibitors, in addition to the 2 treatments that I've discussed, may be helpful, and that will have to be evaluated in future studies. The next topic in the New England Journal concerns liraglutide, and you'll recall that this is a derivative of the saliva of the Gila monster. It's also produced endogenously as glucagon-like peptide. One agonist, and glucagon-like peptide shuts off glucagon release, encourages insulin release, increases the survival of beta cells, decreases gastric emptying, and increases satiety. And liraglutide is a synthetic glucagon-like peptide 1 agonist. And we've looked at studies of this material. It also improves cardiovascular and renal outcomes. And aside from the fact that it has to be given by injection, looks wonderful. Now, could it work in children with type 2 diabetes? And in my generation, children didn't have type 2 diabetes, but now they do. So these children with adolescent type 2 diabetes were randomized to liraglutide or placebo, and all of these children were already getting metformin. So here they are. So there's 66 in the liraglutide group and 68 in the placebo group. They're 14 years old, and they have a body weight of greater than 90 kilograms and a BMI that's in excess of 33. And the endpoint here is, can we suppress their glycated hemoglobin A1 levels? And indeed, that was the case. And they went, the glycated hemoglobin A1 levels dropped by about 1.5%. And their fasting glucose levels got some better too. And their BMI, they lost a little weight, and their BMI was also reduced at the end of, after 52 weeks after randomization. So these are the same responses that we'd expect in adults. But things have to be tested in children, and these children have a BMI of 34, pretty awful, but liraglutide also works in children, and they have the same side effects as adults. There's some nausea was the most frequently reported adverse event, which might also have contributed to the weight loss that we observed. So liraglutide could be given to children, and we would expect the same effects that we see in adult patients. The next topic at the New England Journal is another one of these hunter-gatherer studies, and this is called the All of Us research program. We've already discussed in this round that the Veterans Administration hospitals in the United States have a Million Genome Project already cooking, which involves a whole bunch of demographic and information and data from electronic health records, and the idea of evaluating the genomes of 1 million veterans. But that doesn't seem to be enough. This All of Us research program is about the same story as performed in civilians. And these individuals have been recruited since 2016, and physical measurements are made. Electronic health records are examined. Presumably those are available mostly on people that are sick. People that are well may not need that much in terms of electronic health records. Digital health information, including Fitbits. I had to look up to see what a Fitbit is. Turns out my Apple Watch is a Fitbit. So information from these devices is also to be included in this analysis. Then there's going to be a whole bunch of genomic work done, although in this report it wasn't entirely clear to me if they plan to do exome sequencing or sequence the entire genome or just to do a million SNP analysis. I'm not certain. But at any rate, people from all over the United States are to be included in this wonderful epidemiological survey. I don't know exactly what beta testing is. Couldn't figure that out, but I guess we're on schedule, and the hope is that by 2019, 200,000 people will be recruited, and 1 million people are supposed to be included in this fallout research study, and the hope is that this will come up with new biomarkers, etc. You might have determined from my language that I'm a bit skeptical, but that's the nature of things. So we're looking for genome-wide polygenic risk scores. I think we do pretty well with systolic blood pressure, waist circumference, looking to see if the people are smoking, what their blood sugars are, and what their LDL cholesterol is. But I'm old-fashioned. So the next topic is antibodies. And since I just want to remind you what cold agglutinins are. Cold agglutinins are IgM antibodies. And these IgM antibodies react with erythrocyte surface markers, particularly when subjects are subjected to cold temperatures, or if their blood samples are subjected to cold temperatures. And if we look at peripheral smears from these individuals, we see coin roll phenomena and clumping of erythrocytes. And cold agglutinins are associated with certain infections, mycoplasma, Epstein-Barr infection, or rubella infection. So we know what cold agglutinins are. They're IgM antibodies, most commonly after these infections, but they're also associated with other problems. Now, in this review in the New England Journal, now we're talking about warm autoimmune hemolytic anemia. And these are antibodies that work at normal body temperatures. And basically, these antibodies then are deposited on erythrocytes, although they are fairly non-specific. So we would expect that a direct Coombs test should be positive. So this is a direct Coombs test positive hemolytic anemia. Now, these patients, in addition to getting hemolytic anemia, also have are at increased risk for thromboembolic events, which I guess we could imagine would be the case if their erythrocytes are clumped. And if they have a hemoglobin less than 6 grams per deciliter, they might need to be treated with transfusions. And you could imagine that glucocorticoid therapy plus rituximab might be a good idea. So we're given a scenario here of a 61-year-old woman that comes in with a tachycardia, 15% erythrocytes, has a hemoglobin of around 6 or so, and is direct Coombs test positive. How would we evaluate this patient? Looking at a peripheral smear is always a good idea. And if we look at this peripheral smear, we see some erythrocytes that look pretty good. We see a pale center indicating that they have a concave configuration. There are a couple of schistocytes here, not very many, but what we see here are spherocytes. These erythrocytes no longer have a concave configuration. And what happens here is in the spleen that a part of the erythrocyte membrane has been chewed up by some sort of macrophage. Now these erythrocytes reconvene, but now they're round instead of being concave in shape, and that's why we don't see a pale center and why they look smaller than usual. And they're typical for autoimmune hemolytic anemia. And that's all discussed in this review. Now, most of these patients have an autoimmune hemolytic anemia and no specific cause is ever found. But there are secondary causes that are less common. Lupus erythematosus, might imagine that, rheumatoid arthritis, various problems of that nature. They occur in people with immunodeficiency, including HIV positive patients. They're associated with chronic lymphocytic leukemia and with certain infections. Again, Epstein-Barr virus shows up here, and also hepatitis C, and babesiosis of all things, and even bites from the brown recluse spider that we'll not discuss today. Now, how a direct Coombs positive test works is also shown in this diagram. So these erythrocytes are on their surface membranes have these IgG proteins, and that's how they're detected with specific antibodies against human immunoglobulin. So this warm antibody hemolytic anemia is IgG. Cold agglutinins are IgM. So that would be a worthwhile thing to remember. Then how are these patients treated? Well, steroids seem to work pretty well. Rituximab, in addition to that, is also helpful. And splenectomy is necessary in some of these patients, and perhaps some of these other treatments against autoimmune disease are also warranted in some of these patients. This was the patient from last week that has the cholesterol emboli that we can see here in this section here where these clefts are left after this preparation is after this biopsy is prepared for embedding. And if we look at this CT, we can see this awful aorta and the atherosclerotic disease that it shows. So when this patient got this new aortic valve, we can imagine that material was released here from the catheters that had to be placed in order to perform this procedure, resulting in cholesterol emboli. This patient stabilized with a creatinine of about 2.2 and didn't end up on dialysis. Then here's another patient in the New England Journal. 32-year-old woman, pregnant, has placenta accreta. That means that she has an aggressive trophoblast layer that invades not only a uterine wall, but in this patient also invaded the bladder, which resulted in painless hematuria and this dramatic cystoscopic view that we see here. Now, the patient in the New England Journal is a 41-year-old pregnant woman that comes into the emergency room fairly late in pregnancy at 36 weeks gestation with right lower quadrant pain. And she's evaluated by the dolorimeter, and she's an 8 of 10. So everybody gets very excited. She denies this fever, chills, or diarrhea, right lower quadrant pain, pregnant. What could this be? Doppler examination, the fetus seems to be doing fine. There's no distress here. Urinalysis in this patient, incidentally, was normal. If we look at her white count, it's 14,000. So right lower quadrant pain, white count of 14,000, not much fever. What could it be? That's basically the question. So she gets acetaminophen, I guess, for pain. I'm not sure why. It's not a very good pain medicine anyway. It doesn't have fever. And she also gets ondansetron, which is a serotonin receptor antagonist against vomiting, in case she does any of that. So what we learned from the discussion is pregnancy does not protect from appendicitis, and lower quadrant pain is found in 85% of all pregnant women that have appendicitis. Doesn't seem to be a problem with preeclampsia here. Her blood pressure was normal and she doesn't have proteinuria. Urinalysis doesn't suggest pyelonephritis, so the discussant here suggests that she probably has appendicitis. Now, in my generation, we didn't have any imaging for appendicitis, but now that's no longer the case. There's ultrasound and also CT, which no one wanted to do in this pregnant lady. So she gets an MRI. And if we look at this MRI, here's the fetus, and he's doing fine, and here's a uterus, and here's his head, and that all looks pretty good. And here's this appendix, which we can see here. I wouldn't recognize it as being enlarged, but it is. And so the MRI is consistent with appendicitis. Then how should these patients be operated upon? Patients with appendicitis are now operated upon laparoscopically. So here we see two women with appendicitis. One is pregnant and one is just a little overweight instead. And the usual approach in non-pregnant women in terms of placing these trocars for this laparoscopic operation are shown here. The largest one, I think, is for the camera, and that's discussed here. But in pregnancy, the surgeons decided to place the trocars a little differently than would otherwise be the case. Technical details are discussed here. I think it's marvelous how they can do this. And they took her appendix out, and she had appendicitis. And 3 weeks later, she had a normal vaginal delivery, and everything went well. In the New England Journal, I also saw this letter to the editor that I thought was interesting. This is a statewide implementation of post-operative opioid prescribing guidelines. Now, in my day, when people got huge abdominal and thoracic incisions for operations, I could imagine that post-operative pain was a problem. But after laparoscopic surgery was introduced, I'm not quite sure why these patients need opioids after an operation. The 6 that I've had, I usually felt better after the operation and didn't need any pain medicine. But at any rate, guidelines were issued for physicians in terms of giving post-operative opioids. And here we see here, satisfaction score was no different, pain score was no different, but the amount of tablets that were prescribed containing opioids was reduced almost in half. Good idea. So here are the guidelines. Laparoscopic cholecystectomy. I would think these patients feel better after their operation. They get 10 oxycodons. Hernia repair, 25 oxycodons. How about none? I didn't understand it, but perhaps you will. Now in the Lancet, the first paper I thought was remarkable, and it concerns poor patients that are tetraplegic after spinal cord injury from either trauma or some other cause, such as a malignant tumor. And what's done in these patients, if you can help them at all, some of them are subjected to tendon-based techniques to move their tendons around to constituents that are still functioning so that they can have more use of their hands. And in this operative intervention, not only were tendon-based techniques used, but nerve transfers were done to try to reinnervate important hand musculature so that the patients could do more than merely shrug their shoulders. I don't know much about the techniques here, but spinal cord injuries worldwide are many, and if these patients have C5 lesions or lower, they would be perhaps helped by these kinds of not only tendon transfers, but also nerve transfers. And these courageous surgeons in Australia performed nerve and tendon transfers to try to help these patients, and the technical details are shown here. And the patients are shown here, and a number of patients were subjected. The reasons for their spinal cord injuries are shown here. Diving is up there, sports, motor vehicle accidents, etc. And the number of limbs that are involved here. And all of this information is shown here, but there are some positive results. This patient can now make a fist. This patient can now open his hand. This patient can now spread his fingers. That means that this hand is now fairly functional so that this patient can drive a machine or perhaps type or serve and feed himself. I thought this was marvelous. And details are shown here. And also the discussion, I think that this is a courageous treatment that might help some patients. Now the next topic in the New England Journal again involves psoriasis. And a standard treatment of psoriasis is, if nothing else, if conventional treatment doesn't help, antibodies against TNF-alpha have been available for a decade. Another strategy would be antibody against IL-23. And IL-23 is a cytokine that has an influence on how many regulatory T cells are produced or not, and whether or not inflammatory T cells are produced. And there's an antibody against IL-23, and in this case it's risankizumab. So risankizumab was compared to adalimumab in these patients with psoriasis. And their degree of involvement is evaluated by various scores, including the PASI score. This anti-IL-23 antibody happens to attack the P19 subunit, in case you needed to know that. So here are the patients. There are 300 in each group. And what we see here is that IL-23 antibody beats TNF-alpha antibody, and after that, the patients were re-randomized. The patients that got TNF were re-randomized to then either get the IL-23 antibody or to continue on the TNF-alpha antibody. And if we look at those results, the patients that got the IL-23 treatment again did better than the patients that got the adalimumab. So the patients that were re-randomized to the IL-23 antibody had a better score than the patients that remained on adalimumab. So it looks like the antibody against IL-23 offers these patients with severe psoriasis an additional favorable option. Now the next paper in the Lancet interests me quite a bit because it involves patients with central diabetes insipidus. Patients with nephrogenic diabetes insipidus were not included in this study. And this same group published a paper in the New England Journal where patients with central diabetes insipidus and patients with psychogenic water drinking, that's the differential diagnosis that's oftentimes very difficult to separate. In the New England Journal paper, the patients were randomized to receive a 3% saline infusion and or not, and then copeptin measurements were done. Copeptin is a peptide that's released concomitantly with antidiuretic hormone. Antidiuretic hormone is degraded very quickly in samples. The radioimmunoassay and ELISA tests are not satisfactory, but copeptin is very stable and is a very strong reflector of the release of antidiuretic hormone. So another option to release antidiuretic hormone might be the infusion of arginine. So in this study, arginine-stimulated copeptin measurements were evaluated to separate patients with diabetes and central diabetes insipidus from psychogenic water drinking. So this is a prospective diagnostic study where a cohort was recruited from the university hospital in Basel, and a confirmatory cohort was recruited in Germany from the University of Würzburg. This is the story. The investigators indicated that they've already published this paper on the use of hypertonic saline-stimulated copeptin measurements in the diagnosis of polyuria polydipsia syndrome to discriminate between diabetes insipidus and primary polydipsia. Hypertonic saline has some problems, and it might cause heart failure, and it might cause hyperosmolality and a bunch of other problems. But arginine, that stimulates the anterior pituitary to release prolactin and growth hormone, apparently also results in antidiuretic hormone release. So that's what's done here. So all of the participants, patients with nephrogenic DI were excluded, and the participants underwent a standardized arginine infusion, which was performed in the mornings after an overnight fast. And then these patients then underwent sequential measurements of copeptin release at 30 minutes, 45 minutes, 60 minutes, 90 minutes, and after 2 hours. Now, these patients were hospitalized, but I would imagine that this test could also be performed in cooperative patients on an outpatient basis. You'll recall that the classical test for this is to lock these patients up and perform water deprivation for 16 to 24 hours, which has a whole bunch of problems and is not very reliable. And the end product, the end test in the water deprivation approach was measuring urine osmolality and then giving the patients DDAVP to see if they could concentrate their urine. But this is how this was done. The developmental cohort and the validation cohort, pituitary lesions in these patients, which might cause diabetes insipidus, and some of these patients had psychogenic water drinking, etc. And the idea here is see if the patients with have an increase in copeptin with infusion of arginine. And we see here that the patients with primary polydipsia have an increase in copeptin levels, and the patients with diabetes insipidus of a central nature have no increase in arginine. Then we have some patients that have partial diabetes insipidus compared to complete diabetes insipidus, but separating these patients with this technique, again, looks pretty impressive. So again, patients with partial diabetes insipidus, complete diabetes insipidus, and primary polydipsia, the copeptin levels after arginine infusion was effective in the primary cohort as well as in the secondary cohort, indicating that this test might even be better than infusing hypertonic saline in order to make this diagnosis. And if we look at these ROC curves, they're extremely robust. A perfect right angle here, 100% sensitivity, 100% specificity would be a perfect test. This test isn't quite perfect, but it almost is. And these are very impressive ROC curves indicating that this approach should be able to separate these patients with a high degree of reliability. Now, the reviews in the Lancet Genomic Medicine, at least they didn't call it precision medicine. So this might be the approaches that could be used in this all of us studies. And the first review is on the value of taking a family history. I think this is wonderful, and I'm all in favor of taking family histories, because with that we can learn a whole bunch of things about patients, whether or not they have a alpha-1 antitrypsin deficiency, or if they have a risk of hemochromatosis. And I think abdominal aortic aneurysms, the best indicator would be whether or not the people smoke, but that also is indicated with a positive family history, incidentally. So all of that's discussed here in great detail. I think taking a family history is wonderful. And in the era of genomic medicine, it's certainly indicated. And the next review in terms of genomic medicine is measuring clinical outcomes. This is also important, and we can look at mutation in these various genes. We've discussed them in this exercise on multiple occasions. I have nothing against gene testing. The only thing that I would like from the genomic people is that the genomic tests have to be subjected to a rigorous analysis in terms of sensitivity and specificity, positive and negative predictive value, just like any other test that we perform in clinical medicine. So I have nothing against that. So we'll close with this question. Not quite. Okay, this is a 59-year-old woman that comes to a emergency room with signs of heart failure. And some clinical signs of cardiac tamponade apparently were present in this patient. So you're asked, which of these eponyms is associated with pericardial disease? Beck's triad, that certainly is. Kussmaul's sign, that certainly is. Broadbent's sign, that certainly is. But Erdheim-Chester is not associated with pericardial disease, although, as we're going to learn, it can produce pericardial disease, but it's not an eponym for pericardial disease. So that's the one that's not associated. So Beck's triad, low arterial blood pressure, distended neck veins, muffled heart sounds. No brainer, okay, easy. Kussmaul's sign, actually seen more with constrictive pericarditis. This means that the neck veins get distended when the people breathe in instead of collapsing. Broadbent's sign is also similar. This involves the 11th and 12th ribs, which are indrawn with this sign, which means that you have to take the people's clothes off in order to make the diagnosis. And Erdheim's Chester is a histiocytosis that causes a whole variety of different things outlined here in German. And this histiocytosis is associated with the same BRAF mutation. This is not a malignant disease, but it's associated with the same BRAF mutation that we've seen in patients with malignant melanoma. So here's the story. 59-year-old lady comes to the emergency room. She has swollen ankles. Her blood pressure is normal, not even low. And we're not told what happens to her neck veins when she breathes in and out. Might have been helpful. Somebody might have also looked for pulsus paradoxus. Her heart rate is 35. So an EKG is done, and she doesn't have any P waves. So it sounds like she has heart block. But apparently she doesn't get admitted to the hospital. Somebody puts her on digitalis, and then she travels to the Philippines. She made it. So in the next place, I guess, she has the same problem. So an MRI is done that Maybe a physical diagnosis looking for a Broadbent sign might have also been indicated, but an MRI indicates that she has a pericardial effusion. Then a bunch of other tests are done, and indeed she has an infiltration with non-Paul Langerhans histiocytes, and she has this BRAF mutation. That's Erdheim-Chester's disease. I've encountered this. Ralph Kettlitz and I published a patient with this. She didn't have pericarditis, she had knee pain. You can look it up, but you should also know what Erdheim-Chester's disease is. Thank you very much for listening, and if you want to hear the same nonsense in German in 10 minutes, here are the pictures. Big pericardial effusion, we can see that. Involvement of the kidneys, biopsy shows these histiocytes, positive stains for that. She even has a CNS lesion. Thank you for listening.